Thank you very much for this warm introduction that makes me feel at home even more than I felt before, which is already a pretty high level of feeling at home. My task today is to talk about adaptive responses to chronic intermittent hypoxia. I have no conflicts of interest on this, but I think it's an important approach we should all have in medicine, because we are used to consider. Oh, sorry. Okay, sorry. We're used to consider mainly the bad aspects of diseases. So we are dedicating our attention to findings positively related to diseases. But reality is not black and white, so there may be also positive effects of diseases that we usually do not consider. And for intermittent hypoxia, this is also valid, it is no exception. And so the question I'm going to address in this talk is, do we have any evidence that intermittent hypoxia may evoke adaptive responses besides the maladaptive responses we are usually considering in our daily life? And that are those where most of the attention in the literature has been given. So we have to start with some physiology and especially the responses of the carotid body, that is the main sensor of hypoxia in our body. So in the carotid body, you see that sleep apnea, so intermittent hypoxia causes an increase of xanthine oxidase with a lot of radical oxygen species that produced in the carotid body that have produce an activation of the HIF-1 alpha pathway and block the HIF-2 alpha pathway that is more protective, so counterbalancing the HIF-1 alpha effects. And this further produces radical oxygen species, and eventually it will increase the carotid body chemoreceptor, so the response to hypoxia, and decrease the carotid baroreceptor responses. And this explains why on one side there is an increased sympathetic activation, and on the other side there is a less control of blood pressure responses, which leads to hypertension. And the system, so this is molecular basis of the systemic hypertension, not only during intermittent hypoxia exposure, so during the night, as I will show you in a later slide, but also during wakefulness. But there are also, beside the acute effects of intermittent hypoxia, there could be also epigenetic changes by which these changes become not reversible, but stable in the body. And this has already been shown, for example, for populations that live at high altitude, like the Andean or the Tibetans, for chronic continuous hypoxia. So it is a pretty complicated story, but we know that everything happens at the level of the carotid body. And as I said, there may be short-term responses mediated by the xanthine oxidase activity, intermediate responses that are mediated by the activation of the radical oxygen species through transcriptional changes, but there are also these long-term, long-lasting epigenetic changes. So what happens, and we need here some experimental evidence, to blood pressure. Now, in chronic sustained hypoxia, so if we go to high altitude, what happens is that from sea level, our ventilation in hours and days or months will increase, and also blood pressure will increase after a few days. But eventually there will be a hypoxic desensitization that will bring also blood pressure down. So chronic exposure to hypoxia evokes some changes that are reversible and that more or less are adaptive. But this is complicated because this is just what happens in the long term. you see that there is a neovascularization of the carotid body that brings to the carotid body more oxygen under conditions where oxygen is not that much. And this desensitized the carotid body, but there are also activation of other systems. And so there is less activation of the central nervous system and less responses for ventilation and blood pressure. So it's already this, that is an adaptive, well-described response, is already complicated enough. Intermittent hypoxia is more complicated because if you have an animal that has never been exposed to intermittent hypoxia and you exposed it to 10 cycles of acute intermittent hypoxia, you see from 1 to 10, you see that this animal will increase the efferent activity. So the carotid body nerve will bring this activity, but then as the intermittent hypoxia subsides, then everything goes back to normal. If an animal instead has been subjected to intermittent hypoxia exposure chronically, and then we superimpose 10 cycles of acute intermittent hypoxia, you see first that the first response is much higher than in the control animal, but second, that there is an increase not only of the acute phasic response to hypoxia, but also of the tonic activity of the nerve. And that tonic activity remains high even when the acute intermittent hypoxia exposure has been stopped. And this is called long-term facilitation. So you see here, in summary, in white is a control, goes up and then stays down. The chronic intermittent hypoxia exposed animal responds a lot more to acute intermittent hypoxia and stays activated after that. If you expose animals to sustained hypoxia, as I showed you in the graph before, you see acute intermittent hypoxia on top of chronic hypoxia, sustained hypoxia, evokes a small response and no sustained hypoxia afterwards. This thing is mediated, all this is mediated by HIF1 alpha, as I've shown you in the first slide with a schematic and simplified representation of what's occurring. Now, it's impossible to live without any copy of HIF1 alpha gene. So the totally knocked down animal cannot live. But these investigators were able to use animals with only one copy of HIF1 alpha gene in their cells. And this you see, while in the wild type, it happens what I've shown you before. In this heterogeneous, which is here, I don't know why this moved, you see that there is a small response and no sustained hypoxia. So the HIF1 alpha activation inside the carotid body is responsible to trigger all this cascade of events that follow during chronic intermittent hypoxia exposure. And this is what happens in humans during sleep. You see that in patients with sleep apnea, you have an increase in sympathetic nerve activity, which is the effect of the stimulation from the carotid body to the brain stem. So this is the efferent pathway. And you see that there is an increase in blood pressure after each apnea. And as I've shown you before, if a patient has obstructive sleep apnea, his sympathetic nervous activity is much increased also during wakefulness, and this may be involved in the pathogenesis of hypertension in these patients, also during wakefulness. 2 years ago, after a series of papers that were scattered in the literature and mostly regarding experimental animals, there was this paper that is a randomized control trial published in the Blue Journal. So it deserves all our attention because it is methodologically perfect. Otherwise, it would have not been published. So they took patients with severe sleep apnea and hypertension on CPAP, And a group of them was subjected to bouts of short intermittent hypoxia during daytime, with mild hypercapnia, every 2 minutes for 40 minutes during wakefulness, for each weekday for 3 weeks. And surprise, the decrease of blood pressure in the experimental group having the exposure to mild intermittent hypoxia during daytime was much larger than in the control group, where practically blood pressure did not change. So this is the first striking intervention study that we have. But there are other aspects in the same study that also deserve attention. One is that adherence in these patients improved in the experimental group, probably because the critical closing pressure decreased. So there was a positive effect also on upper airway physiology. And this led Danny Eckert, who is a big expert of sleep apnea physiology in the world from Australia, to write this well-thought editorial where he looks at potential harmful effects of hypoxia. That is what we have already looked at, together with some potential benefits like those shown in this study: decreased blood pressure, upper airway stability, and decreased CPAP requirement, and also other possibilities that have not been addressed in this study. However, it becomes crucial to understand the hypoxia dose, the duration of hypoxia, the pattern, the patient's characteristics, including comorbidities, time of the days, medication, hyper versus hypocapnia or isocapnia. So it's a whole world of possibilities that opens up and needs to be addressed to understand better what happens. There are studies on mortality. These are very well known to the cardiovascular field. If you have animals and you treat them with lethal hypoxic exposure, they all die. And this is this line, okay? But if you pre-treat them with an hypoxic preconditioning for a couple of hours before exposure to the lethal stimulus, some of them at least survive. So this is an extreme proof of the potential effects, positive effects of pre-exposure to hypoxia, but this is also well known to people dealing with ischemic heart disease, because it's well known that if you have infarction, but you have already been exposed to some ischemia before the big hit, then the infarct size is smaller and the survival of the animals is higher. So this is known in the cardiological literature. It turns out that, for example, we've known for a long time that old sleep apnea patients die less than young patients. And this Lavie, a long time ago, both Perez and Lena Lavie hypothesized that it could be that because patients were exposed to intermittent hypoxia, this could act as the ischemic preconditioning, explaining the decreased mortality after a long time of exposure. But also, it is possible that if you have sleep apnea and you have been exposed to nightly intermittent hypoxic event, this may confer some resistance towards severe ischemic insults for myocardium and also brain injury. And this is exactly what happens. First of all, this is a very recent study by Professor Gonzas, who is Greek, and so it's an homage to where I am. Even though this is the Penn cohort in Pennsylvania. So they looked at after 8 or 9 years of follow-up and confirmed that in mild to moderate sleep apnea, the major increase in risk, cardiovascular, cerebrovascular risk, is in those less than 60 years of age. So again, it's possible that those older than 60 are protected against the risk because they've been exposed to mild intermittent hypoxia for a longer time. Clearly, if you have also metabolic factors, the risk is even higher, and this is normal because you have more risk factors. So let's see what happens. What do we have? What do we know about acute myocardial infarction and coronary collaterals? This is the baseline study of the ISAC cohort from Spain. Manuel Sanchez de la Torre is giving a talk tomorrow. And here you see that those with non-sleep apnea had a higher troponin peak level compared to those with sleep apnea, and there was also a dose response effect. So the larger the number of respiratory events, the lower was the peak of troponin. And the editorial has this nice figure where, together with individual susceptibility to specific events and organ vascular bed, the clinical consequences may be modulated by adaptive and maladaptive processes or associated risk factors. And sleep apnea is probably affecting both the adaptive and the maladaptive. You see all the things we are usually considering in our patients. So the issue is much more complicated, and what we see is the end results of a lot of factors that may be balancing each other. This is another study from Australia, published more recently, looking at coronary collaterals for in-hospital outcomes. You see that sleep apnea patient had less left ventricular impairment, higher left ventricular ejection fraction, and lower troponin levels, confirming exactly the same trend as seen in the ISAC cohort. And when looking at the coronary collaterals, they found that the documented history of sleep apnea conferred an increased protection in terms of collaterals, whereas protective things like a history of hypertension or beta blockers were against the development of collaterals. This is important clinically because it means that when we treat CPAP, we never consider, for example, when we did with CPAP, we never consider, for example, that there could be adverse effects we are causing in coronary patients. And this may also be the reason why coronary artery disease has never shown in any study any improvement in patients treated with CPAP when they have sleep apnea. So there is a clinical story that we have new instruments to understand. And so this, there are other small studies. For example, in this study, they found that it is obstructive and not central AHI that is important for coronary collaterals, which makes sense because we know that obstructive sleep apnea causes more hypoxemia than central sleep apnea. And also this striking paper saying that the immediate mortality in patients who have a cardiac arrest in hospital is about half in sleep apnea than in non-sleep apnea patient. And also in the subsequent follow-up, the poor neurological outcomes were worse in non-sleep apnea patients. So maybe we should reconsider the entire thing, considering that we are also struggling to get patients do CPAP therapy, and we are also inclined towards more lighter and non-CPAP therapy in our future for treatment of sleep apnea. This is a very interesting meta-analysis putting together all the experimental studies in rodents ever made. This is from the Grenoble group. It's a monumental piece of work, but again, they also highlight that the infarct size is smaller with mild hypoxia, but it may become larger with severe hypoxia, and also the duration of intermittent hypoxia exposure plays a role. So it's better if you have a short rather than long exposure. Cognitive effects, so this I'll be pretty fast on this. This is just a cartoon from an excellent review published in Lancet Respiratory Medicine a few years ago, about 10 years ago actually, that describes that we can have a therapeutic benefit for mild intermittent hypoxia because the good effects overcome the bad ones, whereas after a certain threshold, then the bad effects become prominent. And this could be the shift between a surveillance in moderate intermittent hypoxia against neuroinflammation, so a potentiation of defense mechanism that when they are overcome do produce inflammation and activation in inflammatory cells. And this may lead, together with other aspects that besides intermittent hypoxia, like sleep fragmentation, the bad clearance of amyloid beta, increased tau, and all these things, to mild cognitive impairment and Alzheimer's disease. You know that there is a lot of discussion about sleep apnea being a potential cause of dementia, even though this is pretty hard to demonstrate. And this is a very good recent review showing that intermittent hypoxia conditioning, also at the level of the brain, may counteract some of the aging effects. So again, the molecular mechanisms that are protective come back. And so you see here intermittent hypoxia conditioning may decrease oxidative stress, inflammation, and also improve the bioenergetic efficiency, membrane integrity, and enzyme function. And this is because our energy metabolism is in the mitochondria that are the major organelle that is hit by hypoxia. I'm not going through this complicated slide. It's just to say that acute mild hypoxia has some effects on peripheral chemoreceptor. We have already looked at all these things, but the repeated exposure has a different part of the figure. So the entire picture is pretty complex and not entirely defined. How did I get into all this? Because as I was called by the International Society for Arterial Chemoreceptor to call about adaptive responses to chronic intermittent hypoxia and the clinical evidence from the ASADA cohort. I put my hands in my hair and I tried to see what was the evidence for a major effect of nocturnal hypoxemia versus the frequency of respiratory event. And indeed, you see that nocturnal hypoxemia has some plus, some minus, and this is also a heterogeneous picture. But I want to draw your attention on one of the problems we were encountering in interpreting data. This paper was published by Isolde Boulokaki and so by Sophia's group and all of us. We're all there, Athanasia, it's Pascal, it's me, we were all there. And the main thing of this study was to show that the hypertension risk was still present when we had different ranges of mild sleep apnea. So with AHI between 5 and 11 being better in terms of risk than with AHI between 11 and 15. So this is an increased risk of hypertension. But then I looked at this slide and I said, what is going to say Sophia? Because I'm going to tell things different from what they have published. It's not true. This is not in against, because look at this. The waist to hip ratio confers a risk that is 8 times higher, which means that it is more the lifestyle we should address in patients with mild hypoxia, mild sleep apnea, because it is the lifestyle that is changed, that is going to give us the maximum of health effect as opposed to CPAP. So, of course, things have to be balanced, but it is a completely different way of looking at things. So in conclusion, we do not consider these adaptive responses too much in management of our patients with sleep apnea, but we should. And we should change our way of thinking in terms of positive and negative effects of treatment. Clearly, we do need more data on adaptive responses before we can use mild intermittent hypoxia as treatment, because the good study, perfect study published in the Blue Journal was the intermittent hypoxia exposure was done in the hospital. So it was a proof of concept study more than a real suggestion for treatment. Think of the dose of hypoxia to be controlled in patients who often have comorbidities. So more than considering this as a potential treatment, I consider that this is really important in understanding the way we should treat our patients. It is the attitude towards the patients we already have. Because in asymptomatic patients with mild sleep apnea, we should look at lifestyle factors, and that we should treat also with alternative treatments, because the positive effects of CPAP have only been demonstrated in severe sleep apnea patients, not in mild to moderate sleep apnea patients. Thank you very much for your attention.